Good afternoon, everyone. My name is Umar Farooq, and I will be starting today's session with few announcements. If you have not already done so, please type your email and name. I think one of us will be recording because eventually you will get your CME credits as a result. Please mute your mic if you are not talking. And this session is recorded. Really for the quality improvement and education purposes. In the spirit of ECHO, all teach, all learn approach, we will be on first name basis. So I think we all know the Hub team and I will be speaking. So allow me to share the my screen. All right. Can you all see my screen, the first slide now?
Yes.
Okay. So, and can you still see the mode is okay? Everything looks good?
Yes, looking good.
Okay. So I think today we will cover the ANCA associated vasculitis. I will just briefly go over some classification of vasculitis in general, then touch base on ANCA vasculitis, go over some histological patterns. I have a case, and we will discuss also the some of the trials for treatment. These are my disclosures. Nothing relevant to this disease condition. So let me present a case of a patient of mine who I have been taking care since 2006, 2007. So he is at that time, I think, was 64 in 2005 with the history of high blood pressure for 2 decades. His original presentation was acute kidney injury, creatinine 2.3, hematuria, proteinuria with 2.8, and at that time he has p-ANCA positivity with myeloperoxidase. His biopsy showed 7 out of 13 glomeruli were sclerosed already. There was classic finding, and I think for the audience, the fibrinoid necrosis is a very hallmark, a classic finding for the ANCA-associated possible vasculitis. There were crescentic GN as well. There were also some lung changes, so chronic inflammatory changes with 3 millimeter nodule at that time. So patient was treated with induction of remission therapy, cyclophosphamide, prednisone for 6 months. This is back in 2005. And then at that time, the maintenance regimen was used was mycophenolate mofetil for 12 months. So moving forward a year later in 2006, his creatinine came down slightly, proteinuria improved, and then kind of, went on and off, and the MMF was actually continued beyond 2 years. And then I think between 2008 and 2011, the creatinine stabilized between 1.5, 1.8, and his proteinuria declined, but his ANCA remained positive until 2012. His hematuria was resolved, proteinuria was less than 500 milligram, ANCAs were negative, and I think at that time, one of those visits, his MMF was stopped. So let me go to the next slide by this one. So in 2015, he had a relapse. So the point I want to make is, so there was initial disease, he was treated, there was a maintenance of remission, and then in 2005, 10 years after the original, he undergone cholecystectomy, and after that he developed a liver abscess. So he presented with gross hematuria at that time and developed again rise in creatinine from 2.9 to 5 more than 5.6. So he was, I think, kind of treated with IV fluids, was even transferred for the concerns for ANCA, but once we gave him IV fluids, things started to settle down. His creatinine came down, so he was not treated with any of the immunological therapy. We thought that this may be just AKI in the setting of MRSA abscess. Yes, Dr. Masood, go ahead.
I'm just curious that why you, CellCept not azathioprine at that time.
Yes, so I don't know the answer to it because this was the whole treatment regimen was before even I started my fellowship. So this was an ongoing. I think I was the one in 2012 who stopped his medication. Around that time he came to my clinic. So I don't know back what was whether he had intolerance to azathioprine, and it was actually never tried. He was primarily switched from after 6 months to MMF. And I think for the audience, in this disease condition, we have more data on azathioprine, as Dr. Masood rightfully questioned over management. Anything else before I go to the next? So I think when he was in with this cholecystectomy admission, the cholecystectomy was done in an outside hospital. So he was actually transferred to us for hematuria. And because of the liver abscess and active infection, we treated his infection, and we did not treat him with any steroids or anything. And he was sent back off once the creatinine came down. As you could see on the right hand of screen, the first rise in creatinine on arrival, we gave him IV fluids, antibiotics, and creatinine came down very nicely. This is back in 2015 admission. So he was sent back, and then a few months later, I think he was at rehab. So he developed a skin rash, he developed GI bleeding, he developed respiratory failure, and then he was shipped to us again. And at that time, I think the diagnosis of a relapse of vasculitis was made, and we thought maybe the infection and everything kind of triggered the relapse or some immune event. And he at that time was treated with, he needed dialysis. We actually did plasmapheresis on him as well, and he was given high dose steroids along with rituximab. And then I think, again, MMF was chosen as the maintenance therapy. Once he resolved the initial episode of renal failure, he actually recovered to the point that he came off of dialysis. He was discharged without any oxygen, and he's back to his baseline. So a couple of years later, creatinine now stabilized between 3.1 to 3.7, proteinuria 1.1 to 1.5 grams, no hematuria, and his ANCA MPO remained negative. More recently, his creatinine has gone up to kind of high 4s and 5s. He's still not on dialysis, and he still remains on MMF. And I think our decision is to keep him as long as possible. Question is, anybody would have treated him differently? What do you guys think about his course so far? So again, just a point to make that this started back in 2005. This is 2021. He's in his now late 70s. He's a very active guy, not on dialysis, doing fairly well, needs some anemia management, blood pressure management, other things. Any comments from the colleagues, like if you would have managed differently or do different things?
I mean, at that time, about 6 years ago, probably I would do the same thing. But the only question is that now, if this patient comes to now, would we give him a plasmapheresis or not? Or whether we would treat him, with cyclophosphamide or rituximab. But I know that the patient already has some bad infection. You don't want to kill him with the infection complication. So, I probably would do the same thing. Just the discussion, for the sake of discussion, is that whether would you do a plasmapheresis now on this patient if he present nowadays, or you would do the same thing even now?
So I think as of now, he just comes for every 3-4 months, his clinic visits, and he's not having any symptoms as of now. He's
So
on
what I'm saying that this patient would present the same symptoms, I mean, same presentation now after 6
same
years.
presentation. So if he has another relapse, which is, so what would you do? Okay. Yep. I think that's a good question. So anybody, so the hypothetical situation is this patient comes back to you with another relapse and his creatinine, I mean, he may have, say, GI bleeding or respiratory symptoms. What would you do? Anybody wants to take a shot on this?
I mean, obviously, this patient, okay, sorry, go ahead.
No, I mean, I'm just asking. Aurangzeb is here. Dr. Agha, do you want to say something, Daniel?
I think Oves was making a comment. Go ahead, Oves, please.
I mean, this patient, if he did pretty good on rituximab, but again, if he relapsed, I think he needs a different therapy. Probably he would need a cyclophosphamide this time if he relapsed.
This time. So you change the one. Okay, that's a good suggestion.
So, you know,
I mean, the other thing, Umar, is sorry.
go ahead, please.
Well, he's 70 plus, that creatinine is already 5. I mean, I'm not sure if more immunosuppression will be a good option here or not.
I think that's a very nice, valid point.
Yeah, and one thing is, did you do a renal biopsy back in 2015, a repeat biopsy?
No, not in 15. Repeat kidney biopsy was not done, but we did. I think when we did the bronchial washing and somebody did the lung biopsy at that time, and there was vasculitis in the lungs.
So a progressive rise in serum creatinine from, let's say, 2005 till 2021 and 5. I think there will be a pretty broad spectrum kind of IFTA in renal biopsy. And that is only if the kidney size is normal. Only in that case, we may be able to do biopsy. So I think in a relapse now, if the serum creatinine is stays around 5, probably I would not give an immunosuppression for kidneys. But regarding the extrarenal manifestation, I think you suppose that the patient may be presenting with respiratory symptoms. So in that case, that will determine what are we going to do then. Because at the age of 70, with the history of MRSA, liver abscess, it's the matter of saving the patient or the kidney with immunosuppression.
I think all valid points. So I probably were in the same dilemma, I think 5-6 years ago, and
So a couple of comments here. So, you know, whatever happened in 2005, that's kind of ancient history. I think he got a very solid induction. MMF was being experimentally tried at that time. I think the big MMF prophylaxis trials were a couple of years after this, but I'll have to look that up. I'm not entirely sure. But in any case, the guy relapsed on MMF. Now, the relapse therapy was correct. You know, this was before Pexivas. This was in the MePex era. Creatinine was going up. So apheresis was indicated based on the norms of practice at that time. And we were able to place them into some form of remission again. But the critique I would have is if they failed MMF prophylaxis, maintenance, then putting them back on MMF maintenance may or may not have been a solid idea. And this is 2016. So at this time, we already know that MMF maintenance is maybe not that great. This is, I think, after main Ritsan 1 at least came out. So I would probably have put him on rituximab maintenance. This is MPO disease, not ANCA disease. And so the other question I have is the thinking behind keeping him on immunosuppressive maintenance for 5 years in an MPO disease when antibody levels are negative and there's no activity no vasculitic activity that you can judge. It looks like he's got progressive sclerosis of the kidney, and Aurangzeb is right. If you biopsied him now, it'll be an end-stage kidney. So any treatment that I afford now would be directed at extrarenal disease. I don't think there's much left in the kidney to salvage. So, if there's pulmonary hemorrhage or something, which at this stage should become very, very unlikely. But if it does happen, then you'd probably need to treat it based on its own merits. And as at his age, probably rituximab would be the way to go at that point. I don't know if I want to give him cyclophosphamide, but the main question I have is why MMF in 2016 and why for an indefinite period of time?
So the relapse in 2000, so 2012 he stopped MMF, and then the relapse in 15 was he was not on MMF.
Okay.
I think the decision at that time, I don't recall. I think maybe the second time MMF, I think this was the rheumatology who was engaged as well. And this was one of the discussion, and since patient was already on it, was exposed. So without any rhyme, I don't have the best answer to it, like why this was chosen again, but I like that. I think this is a good critique that why not some other forms of maintenance therapy.
So I agree with doing biopsy at that time because I want to see whether the patient, how much is left to be treated. But otherwise, if renal biopsy shows that he doesn't have even close to end stage, 70 obviously is not a very young age, but we have to take in contents that his other comorbidities. If otherwise he's a good 70-year-old, I don't have any problem in starting cyclophosphamide, which I have done. I mean, at least 2 or 3 patients in their 70s, and they did pretty good after that, because obviously those patients did not have other significant comorbidities like advanced diabetes or heart failure. But obviously you have to keep close eye on that, any malignancy or any other complication from cyclophosphamide.
Thank you. He's now, I think, 79.
Yeah, so you would give him 6 months of cyclophosphamide induction again, Aves?
I mean, I treated those patients I'm talking about. We gave them patient with PO, cyclophosphamide, reduced dose. Oh, he's 79.
What if the kidney size is borderline? What if the kidney size is, let's suppose, 9 and grade 2 echogenicity, let's say? Would you do a renal biopsy in that case? What are the odds of patient bleeding post renal biopsy, and what's the policy in general?
Yeah, I think if I'm I have this similar or same situation again, and based on your criteria on the kidney on ultrasound, I would not dare to do the biopsy, because I can make a mental picture of how his biopsy would look on the under the microscope. So because that may not even change much of my management, because I think at this stage, if he has another relapse, it might be based on the extrarenal manifestations. But
Yeah,
again, that's like an individual opinion.
Yeah, on the hypothetical scenario that you posed, that the patient may be presented with extrarenal manifestations and there is a rise in serum creatinine, let's suppose 5 to 8 with active urinary sediments. In that case, I was just wanting to know, would you do a renal biopsy in that case, or even then you go with your clinical acumen?
I think I probably would not do the biopsy, but I think let's see. Since this is an opinion zone, it's not a data zone. It's my own opinion. I would be happy to take other experts' answer on this.
I mean, I'm not an expert, but again, my threshold to do biopsy is pretty low because it's pretty safe nowadays, and it gives you many information, and sometimes you're surprised to the biopsy finding. So again, there's no hard and fast rule here. Nobody is wrong or right. I mean, it depends on your individual, evaluation. As a whole, I do biopsy more often than not, because if the patient is in, particularly the patient in hospital, or easy to be done. So because pretty safe, and I have not seen any major complication from kidney biopsy, thank God, for a long time.
Yeah, so let's assume 2 scenarios, right? let's assume this patient comes in for another visit. He's got low-grade fevers, he's got fatigue, his proteinuria is now 4 grams in the urine, he's got some hematuria, and his creatinine is 7. Everything else is fine. What would you do?
I mean, you lower the creatinine a little bit.
7. He's 5 now. So, I mean, he's already end stage, close to end stage. He's a 75-year-old.
You're right. I mean, then you have to see that what you're getting after doing biopsy or actively treating this guy. I mean,
that's the whole point. That's the point that we are trying to make here, that based on the kidney, kisme kitna jigra hai to do anything more. But I'll give another scenario in a second, which makes things different. But let's dissect this scenario. This may happen next month when he comes in to see Umar. Creatinine is now 7, 3, 4 grams of protein and hematuria. So he says, what can you do for me? So Umar, what are you going to do?
Yeah, so two things come to my mind. One is that from the, is this progression of his disease just like natural progression from all the damage done in the past and without the active vasculitis, or what are my signs and symptoms and criteria or markers for active disease? Because if he's having another relapse of vasculitis, so that is dangerous for his life if we don't treat that. So sometimes you treat vasculitis not just for the kidney, but for the lungs, for other reasons.
But he's got no other symptoms, nothing, just the kidney.
It's renal limited,
renal limited. I'm not going to give you wiggle room, my friend.
Okay. Well, that's good. So my plan is, like, I think if I see any rise in creatinine, so my plan is to consider dialysis on this gentleman, because he's on MMF as of now. So if he has a breakthrough of rise in creatinine, I think, and there is nothing else to suggest that he has active vasculitis in other organs, I would proceed with dialysis.
Yeah, I mean, I think there's something to be said. If he's got good quality of life, he's not on dialysis, maybe you can give him a short jab of steroids. You could probably give him 1 dose of rituximab, 1 cycle of rituximab, to see if you can put something down to sleep. But, there's a very good chance, like you said, that he's going to develop secondary sclerosis, and he's going to develop worsening proteinuria. His kidney is going down in the next 1 or 2 years. In the next 1 year, maybe he should be on dialysis. By all stretches of the imagination, I don't know what his trajectory is, but looking at the trajectory, 2018 creatinine was in the 3s, now it's in the 5s. So he's going to end up on dialysis soon. But the situation changes a little bit, right? Now, let's suppose same scenario, creatinine is 7, proteinuria is 4 grams, but he's also short of breath and has got ground glass opacities on the CT of the chest. So now you're looking at a lung renal relapse, right? And your equation completely changes in that scenario. And so now what you're going to do is you're going to treat the lungs. You've already forsaken the kidneys. So you've done that thought experiment that if this was a renal only relapse, the kidneys are so far gone that you're not going to invest too much in them. But if it's a lung renal response, then you're not talking about the kidneys. As soon as you've determined that this is not pulmonary edema and that he's got alveolar hemorrhage, then you have to treat it. And there you have to pull out all the stops. You have to treat it whichever way you think is right. And so if it takes cyclophosphamide, it takes cyclophosphamide. If you want to do steroids or rituximab, that's what it is. Plasmapheresis in today's time, I'm sure you'll discuss Pexivas as we go along. So we'll kind of have a conversation about that. But in that situation, your therapy is squarely, like you were mentioning, focused on extrarenal manifestations. So it's on the merit of the lung vasculitis that you would treat it. So in that case, OS is probably going to end up giving him cyclophosphamide, or I might give him steroids and rituximab, but we will all agree that this patient would need immunosuppression, but it's only for extrarenal disease. At this point, for renal only disease, not very many people would be very aggressive.
And so regarding scenario 1, where you had a hypothetical situation, the patient had a worsening proteinuria. Once we don't have a glomerular hematuria confirmed, and there isn't any another infection, the biopsy for a person like me, 9 centimeter or 8.9 centimeter with echogenicity raised with this history, I may not like to do a renal biopsy for some reasons. These are separate beyond the scope of this discussion. But in these cases, being in USA, do you use CD163 or things like that to predict any activity within the kidneys? Does it help in any way?
No, I think it's not mainstream. Those are all, being done as research operations, but they're not in mainstream practice at this time. The thing is that if it's renal limited disease, I mean, we all know creatinine of 5 with a 15, 16-year vintage of repeated vasculitic activity, we know there's going to be a lot of scar in that kidney. There's not much to be salvaged. If the guy was completely asymptomatic and this is a dramatic jump, I would probably not biopsy him just because the downside, I mean, what am I going to find? I'm going to find either some vasculitic activity or just chronic sclerosed disease. So I might give him a little bit of immunosuppression to quieten something down and move on with life. But if there's extra renal disease, then I already have that. So if he's got lung hemorrhage, I know that he's got pulmonary vasculitis again, and that changes the equation entirely. I will tell you that I have very rarely seen bipolar disease. I mean, when I say bipolar, I mean lung and kidney disease in ANCAs that have gone to advanced stages of chronic kidney disease. So lung hemorrhage in patients like this is a not very common event, just because I think with the renal failure building up and they being on some form of maintenance, and this patient is an MMF, I don't think he's going to have a relapse that way.
Yep. So maybe I think, if allowed, I would take the opportunity to move to the next segment. So where we have a brief presentation about the ANCA-associated vasculitis. Historically, without treatment, 1-year mortality of Wegener's classic, as described in the original studies, was 80%. And now I think with the current treatment or recent treatment, the survival is reversed. So 1-year survival is now 88% and 5-year is 78%. The death is still happening. If this is within a year, active vasculitis, 19% cause of death, infection, 48% cause of death. So we have to be careful with manage the disease, but also watch for other complications. If the frequent cause of death beyond 1 year is cardiovascular disease, cancer, infections. So this is kind of some nomenclature and a big picture view of the 2012 revised Chapel Hill Consensus Conference classification of all these vasculitis. So either this is kind of the large vessel vasculitis, you remember Takayasu's in giant cell, or it goes to the medium size. So this is Pan or Kawasaki's disease. When you keep going down to the smaller vessels, either there are immune complex small vessel vasculitis or ANCA associated, this one, the POSI immune small vessel vasculitis. So immune complex are your cryoglobulins, HSP, IgA vasculitis, and some of those complement associated, and anti-GBM is somewhere as well. Your ANCA associated or microscopic polyangiitis, the granulomatosis with polyangiitis, former Wegener's, and eosinophilic granulomatosis with polyangiitis or Churg-Strauss. They also looked for some other ways to look at the whole vasculitis scenario. So either there is a variable vessel, which means it can involve different size of vessels, single organ in the skin, CNS vasculitis, or just in aorta, vasculitis with systemic diseases, lupus, rheumatoid, sarcoid, or vasculitis with some other probable etiologies, hep C, B. C is usually associated with cryoglobulinic vasculitis, syphilis, drug-induced, both immune complex as well as ANCA associated. I think the hydralazine is also implicated here, cancer and other conditions as well. So clinically, they may have some constitutional symptoms, fever, malaise, non-specific symptoms, weight loss. If this is ENT manifestation with the nasal mucosa, the ear as well, some ulcers in the mouth, or lung manifestation, all the way from hoarseness of voice to cough, shortness of breath, stridor, wheezing, hemoptysis, pleuritic chest pain, and then hallmark is the alveolar hemorrhages. Kidney GN with hematuria with or without rise in creatinine. So earlier on, we have seen many patients, all they have is glomerular hematuria and mild degree of proteinuria. Skin lesions could be different, purpura in the lower extremities, around the nails, some focal necrosis as well, and eye and orbital symptoms as well. Whereas the ANCA associated, as I mentioned, the three conditions, they all have ANCA. They have on the kidney, usually the focal necrotizing or crescentic GN, and this is pauciimmune on immunofluorescence, predominantly affecting small vessels. And I think commonly seen in older adults. So, and it's associated with specific myeloperoxidase or antiproteinase 3 ANCAs. So pathogenesis, I think we are, and this cartoon, this was from a recent article about, recent publication about the review article. So really, I think we have made some strides in understanding the pathogenesis, and it's both B and T lymphocytes are involved, and eventually neutrophils, as you see here, has this PR3 and MPO, and this kind of activated neutrophil, it causes the all this problem on the vascular endothelium, and then some of the targeted therapies are listed here as well, and I think I will cover some of more, like bortezomib is really attacking the plasma cells. Both rituximab and recently, rituximab is FDA approved for this condition, and then this obinutuzumab, it has some data in the lupus world, but there are trials ongoing. These are anti-CD20 drugs. Some of the other monoclonal antibody, this belimumab, is also, affecting this BAF, which is the B cell, activating factors. And then one of the complement-mediated, drug, this Avacopan, has a trial as well. Let me ask Dr. Agha, I know he explains some of these things way better than any of us. Do you have any comments on the pathophysiology or pathogenesis of ANCA-associated vasculitis?
Sure. I mean, you've done a fantastic job. I don't think I can improve upon that, but I'll just make a couple of points just to kind of drive the point home. So I'll just use your graphic, but you won't be able to see my my pointer. So let's just ignore everything that is to the left of these B and T lymphocytes. Let's just forget about all that for the time being, and just assume, for the sake of discussion, that ANCA antibodies are being produced by the body, and there could be environmental reasons for that, genetic reasons for that, what have you. So these antibodies, which are here in these green Y-shaped forms, are being generated. Now, the next thing that happens is that they need primed neutrophils. So the difference between a resting neutrophil and a primed neutrophil is a primed neutrophil is a little angry, and it actually displays PR3 and MPO on its surface. So in this cartoon on the neutrophil, you're looking at these green boxes, which are PR3, and MPO, the blue triangles. They're sitting on the surface of the neutrophil, and an active neutrophil will actually move these from inside the cytoplasm to the surface. And this neutrophil activation can happen due to infections like a sore throat or a fever or something else, which just primes those neutrophils because of Th1 cytokines, and they produce these, they extrude these PR3 and MPO molecules to the surface, and that provides the ANCA antibodies a target. So now what happens is that the ANCA antibodies come in and they attach to this target on the neutrophil membrane. Two things happen after that. One is the neutrophil goes into a burst reaction. And the second thing is that you will have complement activation. And those are the areas which we are now looking at. So there's something inside the neutrophil called NET, neutrophil extracellular trap. And this is just, I always use the example of spidey webs, like Spider-Man throws out those little webs. These are little webs of DNA material which trap actually bugs and allow for their opsonization to cells that would kill them and eat them. So it's a defense mechanism. But in these patients, there's a problem in removal of nets in a timely fashion. And so now you're seeing extra nets coming out. Nets are incredibly pro-inflammatory, so they actually generate an inflammatory response. And since these activated neutrophils are now tethering on the vessel membranes, on the rightmost side of this graphic, you're looking at this neutrophil stuck to the endothelium. It's spitting out these nets, and these nets are then causing the vascular endothelium to become activated. More inflammatory cells are triggered in. There's ANCA running around, so more ANCA then attaches to those activated cells, and you have this forward loop of ongoing inflammation on the vessel wall. And that's where the pathology of ANCA-associated vasculitis happens. It's in the small blood vessels. The neutrophils come in, and the neutrophil elastases and gelatinases and all that stuff comes out. The histones comes out. When the histones come out, they actually trigger the coagulation cascade. So you have this, massive inflammatory process that starts on the vessel wall as well. So the histopathological hallmark of ANCA-associated vasculitis is fibrinoid necrosis, because it kills the vessel wall. So when you look at it under Masson's trichrome, you see this red goo inside the vessel wall, and that's because the neutrophils just killed it. And I'm sure Umar will have some pathology slides. If you don't, Umar, let me know. I've got a couple of pathology slides. I can pull one of my presentations up and we can walk through that. Now, also this NET business is now going to start linking what's happening on the rightmost part of this graphic to what's actually happening on the leftmost part. And so what happens is that these nets can actually signal through antigen presenting cells, through TLR9 and MyD88, and they can actually engage the adaptive immune arm, making them go up and make more ANCA antibodies. So there's a forward feedback loop in producing more antibodies as well. And therefore, that then dictates how we want to treat this. We want to cut off antibody production. So we're looking at cutting it off either through proteasome inhibition, which is your Velcade, bortezomib, or through CD20 depletion, which is your B lymphocytes making antibody. Belimumab, which is now being used very frequently in lupus, is a transitional cytokine inhibitor. So it actually decreases the recruitment of B cell transition in secondary lymphoid organs during an active immune response. And then, we have our usual steroids, etc., to dampen down the inflammation itself, and then targeted therapies through complement cascade blockers, because that's what's going on top of the vessel. Most of the damage that's happening is because of the neutrophil stuff and the complement. So it's a very classic small vessel vasculitis. But the interesting thing in this is that the damage that is happening is precipitated at a distance. So the neutrophil comes in, it's already primed, it's already got this ANCA antibodies attached to it. Then it comes in and bumps into the vessel wall and starts leading to this inflammatory damage. So that leads to a very peculiar set of findings on kidney biopsy. And when Umar goes over that, we will discuss those. So I'll give the mic back to you, Umar.
No, but thank you. I think this is best. This is most excellent explanation, and I think having this picture in front and then how you explained that was great. So let me ask you, and then have all of us think about another fact. Is ANCA a pathogenic antibody? So that there's a question. I think the the clinical scenarios are that, anti-GBM, we know that you monitor the antibody, and there is more direct or more clear association with having anti-GBM and the pathogenicity and disease activity on the clinical. We know that PLA2R, for example, has very clear-cut association recently. Now we know more about it with the membranous in the primary. So let me ask, let's have a discussion about, is the ANCA antibody pathogenic? So in the lab, area, now we have more and more data that yes, the ANCA is pathogenic. In the clinical scenario, can you use the ANCA titers as a marker of pathogenicity or disease activity? For example, if somebody needs a transplant and they are more than a year late out, but still have a little bit ANCA here and there, or a patient who's in remission a few years out, and they may have the ANCA presence at a low stage. So what's the jury out there about the ANCA? Let me ask the experts.
Let me just modulate that question a little bit, Umar, because you're asking two different questions. So the first question is, are ANCA antibodies pathogenic, right? The second question is, does ANCA antibody level correlate with disease activity?
Disease activity, yes.
So those are different questions. So I just wanted to make sure that I pointed that out. But yeah, I'll let people weigh in.
So anybody wants to take a shot on this?
As for a patient who needs a transplant, patient is in remission for over a year. Otherwise there's no sign of any activity. In that case, the protocol, at least in our region, is that no, that is not a reason to hold on or delay his or her transplant. Although maybe not available now, maybe in near future there will be available some more sophisticated tests when you can check some epitopes on that ANCA, which are suggested of activities, and if there's not, then suggested of really quite remission. So the short answer, at least in our practice, is no, is ANCA level doesn't need to be monitored in a patient is a complete remission clinically, and it should not delay or hold on his or her transplant.
We have the same protocol. Aurangzeb, you raised the hand. You want to talk?
I think it's very well said. That's why I learned by hand, because I think whatever Dr. West was saying, I think that explains the whole theory.
Okay. Some other answers? So I think I know Dr. Agha, he's probably taking a call. So for the transplant, for the clinical association, really we have the same protocols here as well. But in the so now there are some association and some data, especially in the animal models, about you inject ANCA and or use some of the lab techniques, and actually it can lead to it's a new disease or relapse of the previous disease. But I think in the clinical world, the association is still loose, and we are not basing the presence of ANCA to decide those transplant decisions, although there were some trials done which they did use the titer presence and absence to guide the therapy. So maybe I think I move to the next slide, and then we'll probably discuss this once Dr. Agha is back. So pathology wise, I think we have made this point very clear that there are segmental glomerulonecrosis with crescent formation, and you can see on the right hand side there is global necrosis with the circumferential crescent, and the other thing is the segmental fibrinoid necrosis with perivascular leukocyte infiltration, which I think if you just as we learned the pathophysiology, it makes absolute sense. I think we discussed that point before. So this is another kind of set of slides. In the A, you see that there is active global cellular crescent with segmental necrosis. So you can see that the crescent is like really global. In the B, there is this segmental fibrocellular crescent. I think this is the crescent, and this is your normal glomeruli, and you also see the fibroid necrosis. In the C on this side, there is a fibrous crescent, this one. And I see that this one, and then cells have a lot of activity here too. On the D, there are glomerular in the different stages. So the single arrow shows the active cellular crescent. Okay, the arrowhead is like really this segmental necrotizing lesion. And when you see those double arrows, which are uninvolved glomeruli, you can see these are normal, but here you can see all this inflammation, and this is far gone. Going to the looking at how these histological patterns have impact on the outcomes, and also I think some sort of a classification. So you can either have more than 50% globally sclerotic glomeruli, or more than 50% normal, you call them focal class, or if there are more than 50% has cellular crescent, then you call them crescentic class. And if not, none of these patterns fits, it's a mixed class. It's really like a stepwise upgradation. But you can see that if this is focal, the outcomes are good, but the next bad is the crescentic outcomes. The next outcome, I think the poor outcomes with the mixed, and if this has far gone to sclerosis, then the outcomes are, I think, worse in this study. So again, I think this highlights the importance of the longer the inflammation or severe the inflammation is, it will lead to different stages of diseases and then worse outcomes. So 3 syndromes and some of the presentation or some of the association, or so GPA, like all of these, all 3 has ANCA positivity, but you can see in GPA and MP is your GPA is granulomatosis with polyangiitis, MP is your they both have 90% ANCA positivity, whereas EGPA only have 40%. PR3 is predominantly associated with GPA, whereas MPO is predominantly associated with MP. I always remember MPO, MPA, and this is renal limited. Kidney is the only organ, whereas GPA you can have nose, sinus, lung, kidney, joints, eye, other organs as well. In both conditions, GPA and MPA, you see a lot of renal involvement, whereas in Churg-Strasser, which is EGPA, you'd see less of that. And again, I think more than 50% RPGN with GPA and MPA. So for nephrology standpoint, I think the GPA and MPA is what we commonly see. Risk factor for relapse. So if this is PR3 ANCA, it tends to relapse more. If there is lung involvement, again, I think it's the hazard ratio is 1.7. And if all of these 3 things are PR3, lung, upper respiratory, the hazard ratio is the highest. So these are the risk for relapse. How do we, Irfan, before we go to the treatment, do you want to share your slides for the pathology? You want me to unshare the screen? You are on mute, I think.
Just 1 second, let me find my presentation. Can you see my slide?
Yes, we do.
Okay, so this is Masson's trichrome, and so blue is scar, and red that you see over here is all fibrinoid necrosis. So what you're looking at is this glomerulus over here, and this is a blood vessel. So what you're seeing here is this focal, intense focal necrosis. So this is all fibrinoid necrosis, and I'll kind of go into the pattern of that a little bit in the next slides. So this is what happens, and we'll kind of go over how a crescent actually forms. On this side, what you're seeing is that the arterial wall is dying. So imagine that those neutrophils were all piled up over here. They were spitting out all sorts of junk to destroy the vessel wall, all sorts of inflammatory cytokines and so on and so forth. And then the vessel wall starts dying. And this is the way the vessel wall cells die, by fibrinoid necrosis. So this is what you see in this. This is classically what you'll see in ANCA-associated vasculitis. This is not what you see classically with lupus, for instance, but for ANCA, you see this. So now this is Jones-Silverstein, of course. So let's see what a normal basement membrane would look like. So these are normal capillary loops over here. You can see this. Now what you're seeing over here is this light pink eosinophilic material in the middle. So this is an area which has actually been destroyed, liquefied by the inflammatory process. So this is your fibrinoid necrosis. Now let's follow this basement membrane. Let's see what's going on here. You see that it's coming down here, but then there's no basement membrane over here at all. So what is happening is, just as we had this arteriole destroyed by the fibrinoid necrosis, and this goo is actually spilling out of the lumen into the perivascular space, what you're seeing here is this inflammatory goo break the glomerular basement membrane and start spilling out into the urinary space. And that is what then leads to an intense reaction where the parietal epithelial cells start multiplying. And that's what a crescent is. So the definition of a crescent is 3 or more layer of parietal epithelial cells in the urinary space. So you can see there's layers of these cells, and these cells are actually activating because all of this inflammatory fibrinoid necrosis, which you see over here, breaks the basement membrane and draws itself into the urinary space and stimulates the epithelial cells. So that's how crescents form in ANCA-associated vasculitis. So if you really look at it, this is the classic picture that you'll see: fibrinoid necrosis, break in the glomerular basement membrane, and then crescent formation, and they follow. So you first get the fibrinoid necrosis, which would be focal. Now, the more you get, the more glomeruli you get involved, tells you that the burden of the disease is high. And that is why ANCA is one disease in which you want to look at involved gloms, but also on the uninvolved gloms. If you have more uninvolved gloms, then you are going to probably be able to get on top of this and understand the disease that we see as nephrologists and the disease that the rheumatologist see is very different. We see this because by this time the creatinine has gone up. What the rheumatologists see is hematuria and then a little bit of proteinuria, and they biopsy the kidney and they see a few gloms with focal necrotizing vasculitis, and that's why they can get away with methotrexate and MMF. When we get into this stage, we're not going to get away with that weak T, so we need the real deal in these patients. So this is an electron micrograph of what you would see in these patients, or more importantly, what you won't see. So if you take a stab at this, what do you see and what you don't see is what the pathogenesis of this disease is. So take a look at this. You've got this basement membrane coming around. This is one capillary loop. This is another capillary loop. And over here, the basement membrane is being destroyed here. But what you don't see in this area, and these are red blood cells here, what you don't see in this mesangial area here is any deposits at all. So you're not going to see deposits in ANCA-associated vasculitis. And this is why your immunofluorescence is dark. And why is that? And it is because this disease is being driven by neutrophils that are already activated. They've got complement sitting on top of them, and that complement is already recruiting inflammatory cells. And therefore, the damage is not through the lytic, the membrane lytic complex, it is through anaphylotoxins, because the membrane lytic complexes are actually sitting on the neutrophils, not on mesangial cells or endothelial cells. So the deposits, when we see them, when we see deposits in lupus, what are they made of? They're made of immunoglobulins, IgG, IgA, IgM, and complement. That's what's in those deposits. But in ANCA-associated vasculitis, those things are all on the neutrophils. They are not in the kidney itself. There's no deposition of antigen antibody complexes. There's no complement generation in situ on kidney tissue, and therefore your immunofluorescence is dark. From time to time, you'll find faint IgG, but that's pretty much what you get. You don't get the immunofluorescence to light up. And that's all I have on the pathology. So Umar, I'll return this back to you.
Thank you. Do you see the slideshow that says induction of remission treatment? So, so treatment, I think we touched this a few times today, as like, the treatment is, what can I do to, bring this active disease down right now? So induction of remission. So then the second phase is really, what can I do to maintain the remission or prevent the relapse? And then I think the other is, how do I treat a relapse? So in ANCA-associated vasculitis, I think there have been several clinical trials. So I think it's important that we discuss some of those key major clinical trials to understand how we arrived to the current, some of the treatment modalities. So the classic treatment has been around the use of cyclophosphamide and steroids. So I think one of the important, this trial, Cyclops trial, 149 patients, and then the intervention was pulse cyclophosphamide every 2 to 3 weeks versus oral cyclophosphamide. So there was no difference between oral versus IV pulse, and there was higher risk of relapse in the pulse arm on long-term follow-up. But again, I think there was another follow-up trial which showed the cumulative dose exposure was lower than the oral. Then the two classic trials, one is this MEPEX, and this followed by the PEXIVAS. So MEPEX was severe ANCA-associated GN patient with creatinine was more than 5, 100% kidney involvement, and these patients received the plasma exchange therapy, PLEX. The control arm received IV methylprednisolone, and then the outcome was renal recovery at 3 months. At 3 months, they noted that PLEX was superior, and there was no difference in long-term outcomes in these studies. Then there was a follow-up larger studies, and I think before in the MEPEX era, we actually performed plasma exchange for many patients who fulfilled those criteria. Then there was a PEXIVAS trial which had 704 patients, and then they had 29% with creatinine was more than 5.7, 98% had renal involvement. So they had plasma exchange with low dose glucocorticoid, and then in the other control was the no plasma exchange, but standard dose glucocorticoid. So their primary endpoint was death or end-stage kidney disease at 12 months. So there was no difference in the efficacy, and there was no difference in subgroup analysis for ESRD, death, or alveolar hemorrhage. So MEPEX showed superiority of the plasma exchange, but when it was followed by PEXIVAS, there was no difference. Anybody wants to have a comment on these? Because there are 3 or 4 more trials. I just wanted to make sure that this is one screen and I go to the other induction trials. I know, Irfan, you talked about the MEPEX and PEXIVAS in the beginning. Any comment before I go to the next slide?
No,
So MEPEX was the older trial, right? And a smaller trial.
Yes, MEPEX was a smaller trial. It was followed by the PEXIVAS. Yes, larger trials.
I think MEPEX was 2012. I think PEXIVAS was 2020. I think Pexivas is remarkable in the number of patients that they recruited. I mean, it is truly mind-blowing that they had 700 patients in this trial. Understand that these trials are very, very expensive. The other, I think, important corollaries. I mean, the question of plasmapheresis, even after Pexivas, is sometimes open, although routine plasmapheresis in patients with ANCA-associated vasculitis is probably not supported now after Pexivas. But even late last year, there was a subgroup of patients with crescentic disease and pulmonary alveolar hemorrhage, which maybe had a signal towards better outcomes. So people who want to use plasmapheresis in very sick patients will find a way to do that. And I know of clinicians who do it. Now I'll give you a very quick clinical anecdote in a sec. But for most patients, this is not probably supported now. Now, the other important thing that comes out with Pexivas is, like in all diseases that we are seeing now, we're beginning to move away from the industrial strength plus prednisone doses that we've been using in these patients. So another sometimes often overlooked subgroup analysis, or arms that we discussed in these patients is the low steroid group. And they actually did, the low steroid group did almost, I mean, actually exactly as well as the high steroid group. So I think some of these very high pulses and very high dose steroids for long periods of time, I think we can start cutting back on after Pexivas, because our other treatments are so effective now. High dose steroids like this open-endedly are legacy from the 70s and 80s, when we really didn't have much other stuff going on. And one of the cardinal roles in which avocapan is being positioned, which is a complement 5A inhibitor, is to spare steroids so that we can get away from using these very awful drugs for long periods of time. Now, the patient I would present is a 30-year-old previously healthy woman. This is a real patient, so I'm going to just, I don't have it written down. So she came to the hospital with hematuria, proteinuria, acute kidney injury. She had fever and fatigue, and she went to her doctor, and all hell broke loose. Her creatinine was like 5. Her ANCA antibodies were very high. It was a C-ANCA driven disease. And we biopsied her, and she had 100% crescents. Every glom had a crescent, and she had pulmonary hemorrhage. So, once I'm sure you're going to go on to rave and rituximab and all that. So everybody think about this patient. And then once we have done all the induction trials, then we'll see what kind of induction would we give to this young lady who had no problems and now is in RPGN with 100% crescents on her biopsy.
So the next group of important, I think, again, like there are some other trials as well, but then I think RAVE. So these are still, we are still on the induction trials. So RAVE has 197, both new and relapsing patients. And this is the rituximab trial, which is 375 milligram per meter square for 4 weekly doses. And the control arm was PO cyclophosphamide followed by azathioprine, the classic treatment. So the remission, which is, there's a BVAS scoring system. This was 0 and completion of steroid taper at 6 months. So there was no difference. So this RAVE actually was better for relapsing disease. So in summary, RAVE, they compared rituximab with cyclophosphamide, and it was non-inferior, even actually better for relapsing disease. So now you have a good alternative from the RAVE trial. Then there was this RituxVAS, which had 44 patients, and it used the rituximab for same 4 weekly doses plus IV cyclophosphamide 15 milligram per kilogram for 2 doses. And the control arm was IV cyclophosphamide for 6 to 10 doses followed by azathioprine. And this showed that in the sustained remission, there was no difference. So in this trial, there was a combination of rituximab and IV cyclophosphamide. More recently, Another major trial, they call it Advocate, 331 patients. In this trial, this new drug, APPNA, as Dr. Aga mentioned, this is a complement drug. This with rituximab or cyclophosphamide, and the control arm was prednisone with rituximab or cyclophosphamide. And with this use of this drug, in the clinical remission, there was no difference. And in the sustained remission, again, the new drug, which is APPNA, which is superior. Irfan, do you want to say something about these three trials, or any other trial you want to touch base?
Yeah, sure. I mean, just a couple of editorial comments on RAVE. Note that in the rituximab arm, there's no maintenance. So they get the 4 doses of rituximab, then they are not on AZA, they're on nothing. So they just get the steroid taper and they get the rituximab and they're done. And yet rituximab was better for relapsing disease in this trial. So that's a remarkable long-term efficacy indication for rituximab in this disease process. Also, look at the entry criteria for RAVE. They actually excluded patients with a creatinine of more than 4. So sometimes I see these patients who are on dialysis and we say, okay, let's treat them with RAVE. Actually, RAVE didn't answer that question. Rituximab, on the other hand, did answer that question. They did take people with higher degrees of renal dysfunction. They did take patients on dialysis. And therefore, we have to be mindful when we are prescribing therapy in patients who are very, very sick. And thirdly, Advocate, this is the up and coming form of therapy for ANCA-associated vasculitis. And again, you look at the arms, and you're taking avocapan instead of prednisone. So you're trying to get rid of prednisone here. And also there's a couple of very recent articles that are looking at C3 levels in ANCA-associated vasculitis, and the subgroup of ANCA-associated vasculitis patients who are low C3, there's a subgroup of that. They are probably the most likely to have a salutary response to avocapan. So.
Thank you.
So, if I could ask a question.
Mm-hmm.
Regarding RAVE, what was the time duration for the remission? Because plasma cells don't have CD20, and it seems to be an angry disease where the plasma cells are firing the ANCA. So in that case, I understand the later remission in case of membranous nephropathy due to the disease.
Sure.
What was the disease remission time versus cyclophosphamide? That's question number 1. And the second question is even more naive, and that is, regarding Paxivas, there wasn't any use of rituximab and cyclophosphamide in both the arms, right?
Say that again, Aurangzeb.
In Paxivas trial, there wasn't any use of cyclophosphamide or rituximab.
In Paxivas?
Yeah, in Paxivas, there was only plasma phases versus no plasma phases.
No.
The patient on standard treatment for that.
No, the plasma. No. Yeah. We stopped doing that kind of stuff after Tuskegee. No, there was standard treatment. Plasmapheresis was added on or not. So in Paxivas, there were 4 groups. The N was 7. I just pulled up my presentation, so
okay.
I've got the groups in front of those. I'm not going to share this slide. I'll just tell you. So there was pulse steroids. So the groups received either rituximab or cyclophosphamide. And then the 4 groups were Plex, no Plex, full dose steroids, and low dose steroids. So that's kind of the group. So everybody either got rituximab induction or cyclophosphamide induction.
All right. And what about the treatment remission in case of RAVE?
And let me see if I've got that somewhere.
I think it was a 9 month.
But basically, let me make a point. So your assumption behind the question, if I may be able to venture to that, is that rituximab is not going to touch the plasma cells, right? And that's a valid assumption, because plasma cells do not have CD20. They lose CD19 and CD20, well, mostly CD20 early, and then late plasma cells would lose CD19 as well. And so they would be immune to CD20 or CD19 manipulation. But it depends on the phenotype of the plasma cell, of how long they would last. So long-lived plasma cells, which are CD38 positive, CD138 high, CD19 low, they can last for decades. So when you get measles shots as children, or if you contract measles, you can find that antibody in your blood for decades. And these are the long-lived plasma cells that live in the bone marrow, which keep producing that antibody. But the antibody that is produced in different inflammatory reactions, so in ANCA-associated vasculitis, the antibody that is produced is by a different phenotype of plasma cells, and they are active. They are tissue-resident plasma cells, and they are active for weeks, but not years. And so the theory is that if you deplete the B cells, then the B cell graduation towards memory cells and plasma cells will be interrupted, and eventually you'll run out of antibody. So I don't anticipate a huge difference in time to response in rituximab versus cyclophosphamide. But as Umar continues with the talk, let me see if I've got that somewhere. I doubt that I do, but I'll try to find it. Does that sort of answer your question?
I think the
Definitely it
time
helps.
for remission was 9 months, right? Everything.
Yeah, but that's, I think the thing is, it didn't differ significantly in both the arms. I've got the time to CD19, B cell depletion count. So we check it through CD19. That was obviously a little bit faster in rituximab than it was in controls.
Dr. West said it's 9 months.
Yeah, to go into remission.
No, it should be faster than that, Avas. It shouldn't
Well,
be
in
9
case
months.
of 9 months, I think it will check the nerves of the physician too.
No.
Because
Usually you get into remission around the 3-month mark.
The
So
average time to.
yeah, so
don't know.
actually, Umar, why don't you continue and let me pull up Rave. I don't have the time to remission. I'll try to find that while you are talking.
Yeah, I think I remember it was not 9 months. It was less than that. It was within the less than 6 months. But I think it would be good that if you pull that. So I think this was just like I kind of knew that by this time we will have the discussion that we will want to see the time line for the trials as well. On the top part is the induction trials, on the lower is the maintenance trials. And I think here you can see that how the NORM-MAPEX were back in 2005, 2007. And then this is Cyclops 2009, Rave Rituximab, which I discussed is 2010. And then there are some long-term data as well. And then more recently, this Advocate trial, which I just presented. And there are some, and this was actually, this was taken from a rheumatology journal. So maybe I think the other presenter did not have this as a part of their publication. Whereas you can see that simultaneously the maintenance of remission, which are below the timeline arrow, so Cycazerum, the Wegenet, the improved trial, Remain, and then this main Ritsan, which is 1, 2, and then now 3 as well. So I will discuss some of these in my follow-up slides. So Irfan, please let me know whenever you want me to unshare, but I will go to the maintenance
Please
therapy.
continue. Please
Therapy
continue.
trial. So maintenance therapy trials, I think it would be good to know that as in the beginning we all discussed, and the point was made that the azathioprine has been, I think, the drug of choice for and then better than even the MMF. And I think in my patient, the question was, why did we not choose azathioprine? So let's see. So Cycazerum, 155 patients, this was the induction was oral cyclophosphamide, the intervention was azathioprine, control was oral cyclophosphamide as well, and the endpoint was relapse at 18 months. There was no difference. So this was so brought the idea of using this drug in place of the cyclophosphamide. And then I think one of the other outcome we found that the MPA relapses less frequently than GPA. So then there are some other trials, but I think the series of this main RITSAN, which involves the rituximab as the maintenance therapy. So we have the option to use either azathioprine, and as Dr. Agha mentioned, there are, if this is like extremely mild disease, then methotrexate. And I think there was a trial as well, which is not included, at least in this slide. So in this main RITSAN trial, 70% with kidney involvement. So induction was the pulse cyclophosphamide. So this was intervention was rituximab 500 milligram day 0, 14, and then every 6 months. And then the control was the azathioprine, because we knew that azathioprine works in the maintenance for 1 year followed by a taper. They looked at the relapse at 28 months and found that rituximab was superior in preventing the relapse. And then I think there were an analysis which showed that relapse occurred after when the B cell starts to return. So this led to, okay, can we do some sort of a tailored therapy? So then this main RITSAN, they have the 162 patients. The induction agent was cyclophosphamide or rituximab, or I think, I don't know about this methotrexate, there are double strexes, but so they, instead of using this fixed dose rituximab, there were tailored rituximab, and tailored was these 162 patients. So, which was 500 milligram dose if there is more than 2-fold increase in the ANCA titers. So based on the ANCA titers, or there was ANCA positivity from negativity or peripheral B cell return. And rituximab was given until 18 months after randomization, and they looked data at 28 months. And they said, like, the tailored therapy still worked. There was no difference. There was no difference in the adverse outcomes, and there were fewer rituximab doses in the tailored arm. So then they went on to this third main RITSAN trial with 97 patients from the main RITSAN #2 trial. They had the same induction agent, and then these patients got rituximab 500 milligram every 6 months for 18 months. So versus placebo, so nothing. And then they looked at relapse-free survival at 28 months. So they found that with the extended treatment, there was less relapse. And again, I think GPA was the condition which had more relapses. So really, they started using the rituximab as compared to azathioprine, and then came up with a tailored regimen versus a prolonged and extended regimen, and found that when you go to this prolonged regimen, there was less relapses. There are some other trials as well for the maintenance therapy, RITA-ZARM, which is 170 patient. And then these patients who had induction with rituximab and got rituximab 1 gram every 4 months for 20 months as compared to azathioprine, and then rituximab was superior in this trial as well. Improved trial, 156 new patients, patient with ANCA-associated vasculitis, induction with cyclophosphamide, maintenance. The intervention was azathioprine. I think this was the older trial as compared to MMF for 1 year, and then relapse-free survival was looked at, and relapse were more common with MMF, and that's why the azathioprine was considered superior to MMF based on this trial. And there's another important trial called BREVIS, 105 patients, and in this trial, this was a belimumab trial with placebo and azathioprine, and again, this is no difference trial. and no relapses were noted in patient who got rituximab to begin with, and then they received this new belimumab maintenance therapy. So these were any comments on the maintenance from my panel experts? Any drug which stands out to you, or any concluding remarks?
Yes, I'll just make a couple of points if nobody else is making a point, and that is that when you're looking at relapse potential, when you're plotting your scheme to do maintenance therapy, you have to look at C-ANCA disease and P-ANCA disease as totally different. So C-ANCAs are aggressive as far as relapses are concerned. You have to be more careful. You have to be more aggressive. P-ANCAs, not so much. So when I'm dealing with a C-ANCA syndrome, I put them on suppressive treatment for 2 years, sometimes 3 years. And what I do is I do fixed suppressive treatment for 2 years, and then I might give them another year, and I use rituximab almost exclusively now for maintenance. And for the third year, I may do a CD19 driven treatment regimen. Whereas in PNCA disease, which is well controlled, I might go to a CD19 driven methodology from the get-go. So that decreases the amount of immunosuppression that I give to the PNCA patients, and I think helps in channeling immunosuppression to people who actually would really need it to avoid a relapse.
Yes, I also, at least I remember 2 patients who were MPA or PNCA, and they went to remission quickly, and their remission remained. And we actually took off from the maintenance therapy after 1 year. So sometimes if you're very, remission is completely completed 1 year, and then you can think about, particularly if they are MPA or PNCA, stopping early maintenance therapy.
So I just saw a patient a couple of days ago. I think he's just discharged. So 79 years old, very healthy gentleman who 6 months ago got a biopsy, ANCA-associated vasculitis, treated with cyclophosphamide, and there was a plan to switch him on, I think, September 30th to azathioprine, and he came to hospital on September 28th with hemorrhagic cystitis and gross hematuria. So complication of, I think we thought it's a complication of cyclophosphamide that he developed this hematuria. So we also have to be aware of some of the complications from these drugs. Okay, so this was one of the, and I think I have 2 or 3 slides left. This was the ANCA algorithm by UNC in 2017. And I think on the left-hand side, they say their approach was mild or moderate kidney failure without pulmonary alveolar hemorrhage. So the options were methylprednisolone and pulse IV cyclophosphamide or rituximab with prednisone for 16 to 20 weeks. To achieve the remission, you go down, and then maintenance with azathioprine or rituximab. And after 12 to 18 months in remission, maintenance immunosuppression may be discontinued with close follow-up. Now, if there is severe disease, at that time, and again, this is 2017, they use plasmapheresis, although I think in the timeline, we looked at the follow-up Plex trial, did not show any difference. So there's difference in the old times. I'm just kind of reminding all of us. So then treatment resistance, if you see that, then if initially you use rituximab, add cyclophosphamide, and vice versa. And I think they use it for 4 months and to achieve the remission. And if somebody has a relapse, then everything was an open game. So the recent, I think this is just published in 2000, very recently in a rheumatology journal. So their approach is if there's a diagnosis of severe GPA or MPA, induction of remission with you consider high-dose glucocorticoids, the pulse, IV pulse, followed by oral glucocorticoids, or I think they want to use as the steroid-sparing regimen as avacopan with either rituximab and or cyclophosphamide, and I think the regimens are listed, and I think they still consider plasma exchanges, 7 treatments in 14 days, and I'm sure there are some criteria listed. There is this new concept of rapid reduction of glucocorticoids, which I think Dr. Agha mentioned. Even there were some of the trials had those dosage listed, like, you see a response, you go rapid reduction. So there is a big push or a movement to try to be steroid sparing and use a therapy which is less toxic. And I hope that in future we go to more targeted therapies which are really attacking some known molecules. And then I think in this the same article, the maintenance of remission at least 2 years. I think they talked about the low dose glucocorticoid, and I think we are probably waiting for some of those results for upcoming trials. The options for maintenance, rituximab considered as first line, 500 to 1000 milligram every 4 to 6 months, or azathioprine, or I think methotrexate is still popular in the rheumatology colleagues. I know some of my colleagues, they still want to do, and this is, I think in the article was the less severe disease. If above are contraindicated, then they are okay with use of MMF, very high dose. And I think there was a trial about leflunomide as well, if you cannot use any of those therapies above. And this is my last slide. So this is where we stand in the rheumatology world, in the nephrology world, and we summarize all the trials. So can I stop share and then we can have some discussion? I see some chat questions as well. I'm sure I missed those. Anything in the chat, Dr. Agha, which we need to address?
There's a question by Dr. Rabia Azmat. Well, ANCA antibody titers are to be correlated with the signs and symptoms. So I think this was probably from the time where we were saying whether ANCA is, sorry, I had to take a call from the ER at that time, so I missed part of that discussion. But anyways, okay.
Okay, I have a question. Can I go ahead?
Yes, please go ahead.
Okay, so back to the same discussion about plasmapheresis in a severe disease. So it takes a big trial like rituximab to not to give plasmapheresis in a patient who comes with the hemoptysis or severe presentation. Even then, I'm sure a lot of nephrologists don't feel comfortable not giving that treatment. Irfan, you just talk about a patient who very young and very severe presentation. So did you end up giving her plasmapheresis?
So what would people do? So let me just recap that. 30s, previously healthy, RPGN, creatinine in the 5s, 100% crescents on the biopsy and ANCA-driven disease. What would you do? I've asked, what would you do?
So a 30 years old female, married, unmarried?
I don't remember, sorry.
Fertility potential or desire to get pregnant?
She's 30, so I mean, you have to assume that there would be some
question is that whether to give plasmapheresis or not. I mean, definitely I will give that because I
well,
would.
Before we go that, what is the induction regimen that
what's the
I would do rituximab. I would do rituximab on this patient.
You would do rituximab on somebody with a creatinine of 5 and 100% crescents. Okay, not unreasonable.
With plasmapheresis and 30-year-old.
You would what?
With plasmapheresis.
With plasmapheresis, okay. What would you do?
Yeah, I think this is where the catch-22 is. I think her age, her fertility potential.
What is the dose of cyclophosphamide at which fertility potential is actually an issue?
I don't know answer to that question. That's a very good question. But that was my general framework of consideration. That
Those normally
I know
when
that
cyclophosphamide.
cyclophosphamide is going to give me quick and early response. But I think I don't know.
Does it? So I was looking up the answer to Aurangzeb's question. And actually the RAVE paper and the supplemental material don't parse it out. They gated the data at 6 months. So they looked at the primary endpoint, which is, remission at 6 months. So they don't really tell us which one got there fast or faster.
So one thing that I find fascinating about RAVE is with rituximab 4 doses, they did not give any steroids. Am I right?
No, they did give steroids.
They did?
Yes, both the arms got steroids.
Okay. And
but one of the conditions was that the steroids had to be tapered down to, I think, a dose of 5 to 10 by 3 months or something like that.
in both of them? Both
Yes.
of the groups?
Yes.
Okay. With rituximab, the thing is, if the things go just too slow, in membranous nephropathy, it's a simmering disease, proteinuria tends to get low, and you can counsel the patient that it's going to get better. But if the patient is having high serum creatinine, the patient is going nuts that I may be going towards a dialysis, and there is so much of panic. So the time duration and the expectations of the patient and the physician needs to be tailored if we're using rituximab to treat an ANCA vasculitis. And this is a problem that I faced. I have used rituximab in ANCA-associated vasculitis. But generally, our anecdotal experience is because there was only less than a dozen of patients and we are still gathering data about them. Cyclophosphamide worked a lot better in all the patients who had a serum creatinine of greater than 4 in general. And regarding the hypothetical question that you posed, I think it's a practical question, 30-year-old female, probably I will also give rituximab in that patient.
Okay.
I mean, that patient for acute therapy, you need something acute to bring down the immunosuppressant. You already given first dose steroids. You already given plasmapheresis, and that's why I would like to avoid the cyclophosphamide.
She has 100% crescents. So
then I don't think that will make any difference between cyclophosphamide and rituximab.
yes, essentially what we used was a rituximab-based regimen, not the RAVE regimen, because we thought that this kidney would be at very high risk for permanent damage if we are not hitting her very hard initially. So she was given pulse steroids and then an oral steroid maintenance for 4 months, I think, and then she was tapered down to 5 and stopped. She received 2 doses of cyclophosphamide, 1 gram each, 3 weeks apart, based on the rituximab protocol. And then she got induction with rituximab 2 doses. And we did freeze her because this, we thought, was the kitchen sink time. We had 1 shot at this kidney and we decided to take it because she didn't have a lot of interstitial fibrosis, but in a glomerular disease, that doesn't matter because the interstitial fibrosis follows glomerular sclerosis disease where the damage comes from the top down. So
The scene was based on what study?
so this was based on rituximab.
The rituximab protocol.
Yeah. So this was the rituximab protocol.
That showed that in that condition, patient creatinine is that high. That's
yes, because in RAVE they didn't have a lot of patients with crescentic disease. They didn't have patients with creatinines more than 4. And only a quarter of the patients had alveolar hemorrhage. She didn't have alveolar hemorrhage. She just had renal limited disease. And then we did plasma exchange on her. She got 3 or 5 sessions. And so this was in December, I think, of last year. And her creatinine today is 1.2, and she's got about 600 milligrams of protein. So she had a complete response, almost a complete response. But this is anecdotal. This is anecdotal.
Right. So regarding a hypothetical question, let's suppose a patient of gout develops an ANCA-associated vasculitis and he is on allopurinol.
Sure.
So what would you do with allopurinol in this case? Is it safe to convert into febuxostat? Is it just the deficiency of data that is compelling us to convert it, or would you hold that and put on colchicine for a while and see?
I switched them to pegloticase. So I
You
take away the
switch them to?
pegloticase. So I
Okay.
just completely avoid the xanthine oxidase arm.
Well, let's
So
suppose you're not in
couple of-
Dallas and you're here in services hospital. Where do we don't have that? How should we do that?
You should then try Ularic and see if that works. I do not know if Ularic has ever been directly associated with ANCA generation of ANCA. Allopurinol is. Other medicines that you always want to worry about, especially if you're seeing ANCA-associated vasculitis or double positive vasculitis, where your ANA is positive and ANCA is positive, is hydralazine, antithyroid medicines, and in the United States, especially, I'm sure Pakistan as well, if somebody's using cocaine, because the levamisole in the cocaine, which is it's an adulterant, and that can lead to generation of ANCA antibodies.
And so what about quetiapine? It has also been reported to be associated with something like that. Have you seen?
I have not had any experience with quetiapine associated ANCA-associated vasculitis, but we have to be careful in not going after onesies and twosies, because you can be on quetiapine. A lot of people are on quetiapine, and you can develop an ANCA-associated vasculitis. So you start getting a signal. If I see 10 case reports, then I say, oh, there's something there. Otherwise, it might just be an association and not a causal link.
So my question, Irfan, is still a health question. So a patient comes to you now who is with the pulmonary hemorrhage, creatinine 4, 5, with vasculitis, ANCA. Would you give a plasmapheresis or you will not give?
We did plasmapheresis in that particular patient just because I thought that I had one shot at that kidney. But if I see focal necrotizing vasculitis, a few crescents, a little bit of pulmonary hemorrhage, that's what the Pexivas trial actually told us, right? That in those patients, plasmapheresis really doesn't make a difference. So in those patients, I don't do plasmapheresis anymore. This patient I presented as, oh my God, this kidney's gonna be dead if I don't do whatever I can. It's a young kid, and so I did what I could. So that's where sometimes your practice is, and sometimes we do things which are not 100% kosher based on data. So if you really critique that based on Pexivas, the reason I actually succumbed to that, because one of my partners was taking care of the patient. It was a Sunday, I distinctly remember that. So we were talking about it, and I was actually on a conference. There was an ACR conference, an ACR update going on, and it was just serendipitous that they came up with this abstract, and they said, in a Pexivas subgroup analysis, people with RPGN, high crescents, and a significant alveolar hemorrhage, there was a signal that pheresis may have helped actually. So it said, well, I've got something to stand on. Let's go with pheresis as well. But yeah, with the case that you're hypothesizing of S, I would probably do pheresis in today's time. So you'll probably violate that rule in one case or the other where there's something which looks terribly wrong. But for the most part, if you're seeing somebody with focal necrotizing vasculitis, a few crescents, creatinine is in the 2s, 3s, 4s, they've got some alveolar hemorrhage. Those are the patients which would probably respond just as well to a strongly constructed induction regimen.
So we have a good question by Dr. Hina in the chat. I think we should try to it's a good patient. Dr. Hina, are you able to present this patient yourself, or you want me to summarize? Is she still here? There's one new. Okay, yes. So could you please tell us about your patient yourself?
Assalamu alaikum.
Walaikum
Can you hear
salam.
me?
Yes, we can.
Okay, I have recently encountered a woman aged 64, and she was known case of diabetes for past 20 years, and she was on oral anti-diabetic drugs. And her diabetes was well controlled, and she was uncomplicated diabetes. And she recently presented with fever, with mild cough, and one episode of hemoptysis, followed by decreased urine output. She was presented at a private setup and where her workup was done. At the time of presentation, her renal function was deranged and her creatinine was around 8 or 9. And at that time, urine was showing active sediments, and she was initiated on hemodialysis. And her workup was done at that time where her ANA was positive and her double standard DNA and complements were negative. Also, her ENA profile shows the anti-SCL70, which was positive, and her P-ANCA was a strongly positive 3+, and her C-ANCA was weakly positive. So after doing her hemodialysis and her creatinine letting down, her kidneys was normal, so renal biopsy was done. And renal biopsy was showing 14 glomes. Renal biopsy was showing 24 glomes, out of which 14 was globally sclerosed, and there was mild to moderate tubular atrophy, as well as interstitial inflammation was mild to moderate. And IMF was totally negative. And so there was some RBCs in the vessels, and in the conclusion, they wrote that it is chronic sclerosing gene, focal necrotizing gene, and active or healed lesions are present, along with hemolytic uremic syndrome. So after biopsy report, uh, somebody has given her methyl pulse 500 milligram for 3 days, and also her plasmapheresis was initiated, and total 6 sessions of plasmapheresis was done. And along with that, her hemodialysis were continued every 3rd day. And after 6 sessions of hemodialysis, she was put on oral steroids as well as on oral endoxin, oral cyclophosphamide. And after 3 to 4 days, she presented to another nephrologist who stopped her endoxin, oral cyclophosphamide, and told her that she is a case of CKD and she has to continue with her hemodialysis. And she was put on low dose steroid along with the conservative treatment of chronic kidney disease. So considering this, I was in confusion whether to stop her immunosuppression at this time. Why not to continue her cyclophosphamide or Ritux at present? She is only 15 to 16 days has passed from her recent illness, and we have 14 glomes was globally sclerosed, but 10 were normal. So why, what would be the next step for management in this patient? Whether to continue with the immunosuppression or whether to continue with low dose steroid? Um, Anything else you want to ask?
I think this is good description. So my expert panel members or anybody, do you want to?
Yeah, just had a quick question about this HUS that was thrown in the middle.
Yeah.
What was that about? I didn't get some clarification. Dr. Hina, could you please tell us what they meant by the HUS? Because HUS is actually not a biopsy diagnosis, it's a clinical syndrome. So did they see thrombotic microangiopathy on the biopsy? Is that why they're calling it quote unquote HUS?
Sir, there was something showing in the vessel. There was some activity in the vessels. On that behalf, they have told that it is in the conclusion they have written that there is HUS as well. But on clinical parameter, on lab exam, on CBC report, on peripheral smear, there was no sign of HUS like schistocytes or any active RBCs like matlab any.
So I think what they're looking at is necrotizing vasculitis and some thrombotic microangiopathy. And so they probably inartfully phrased it as HUS, but both these things obviously are very, very well described in ANCA associated disease as well. So it looks like this is more consistent with ANCA related or P-ANCA related syndrome. So I think the question is open for everybody. What would you do, guys?
Yeah, I would continue to treat with the induction therapy as it was originally started with cyclophosphamide and prednisone. Patient already completed plasma exchange. This is one of the conditions, even if when patients are in acute renal failure and or on dialysis, and I think you showed that 14 out of 24 are glomeruli are gone, but there are a few which are showing cellular crescents, not, so I think there is active disease and maybe in the various, stage of the disease. So I think we should keep going with the induction therapy. If patient needs dialysis or dialytic support, please continue to provide that and wait for some time and give it some time for the induction regimen to show its results.
Yeah, I think I will probably do the same. I think immunosuppression should be offered, and the benefits and the risks, of course, should be explained to the patient. And the patient should be the part of the diagnosis and treatment. And second, if the SCL70 was positive, how does that fit into the equation? And there is a trend towards steroids not being so good for a patient of SCL70 positive. For a patient like that, does it mean anything that we should be tapering steroids a little earlier and continue
Yeah,
with
sure, but with negative immunofluorescence on the biopsy, you have to hypothesize that the antibody that is driving the illness is the ANCA antibody. So your treatment is probably going to direct towards the ANCA antibody, and we would probably ignore the ANA or SCL70 because they don't seem to be pathogenic at this time. That's kind of how I would look at it.
all right.
Yeah, so bottom line is that I agree. The patient should be continued the PO cyclophosphamide with reduced dose because of renal failure and steroids for some time. And after that, she should be on,
She's probably going to be left with significant chronic kidney disease, but she may come off of dialysis for 6 months, 1 year, 2 years, which is precious for a 64-year-old. And you can actually prepare for a preemptive transplant in that period of time as you keep her off of dialysis. So I think it's worth treating. I wouldn't take that treatment off. We take people off of dialysis all the time who need dialysis as a bridge while our immunosuppression fixes the kidney. So I think I wouldn't be hasty in stopping the immunosuppression in this patient. So one thing that we sometimes see, as Umar puts up the next case, is this double positivity issue. We've kind of talked about that a little bit with drugs, but sometimes you see a false positive signal when you've got high dose ANA. So when you've got, sorry, not high dose, high level ANA. So somebody's got high level ANA in the blood, and you do an ethanol prep screen, which is what they use for the indirect immunofluorescence for ANCA. So understand there's 2 different ways you commonly check for ANCA. One is the screening test, which is the indirect immunofluorescence, which is immunofluorescence on an ethanol prep slide. And the other is by an ELISA for the 2 major antigens, screening for the 2 major antigen targets that we look for, the PR3 and MPO. So if you've got high level ANA in the blood and you're doing an ethanol prep, that high level ANA is going to stick in the cell and actually give a false positive ANCA signal, which usually is in the p-ANCA formation. So if you've got high dose ANA and you've got an indirect immunofluorescence, which is reporting p-ANCA, then you want to absolutely run the PR3 and MPO ELISAs before you say the ANCA is really positive. It may just be driven by the ANA. So I was thinking about that when we looked at this case. Obviously, you don't have PR3s and MPOs, but the fact is your immunofluorescence in the kidney, unless that's a false negative immunofluorescence, but the immunofluorescence in the kidney is negative. So I tend to believe that the ANCA is real.
So, Dr. Irfan, let's suppose if this patient had onion skin layering on the vessels in the rest of the 10 glomeruli with SCL70 positive.
Sure.
What would you do then?
That would be a totally different case scenario then. This won't be the ANCA case scenario. So, we kind of have to kind of pay more attention to the SCL70 and, think about, what's going on in the kidney. At this point, you've got a dark immunofluorescence and you've got ANCA in the blood. So you have to agree that probably the ANCA is what's driving the pathogenic mechanism. So different scenarios. I've seen people with bona fide ANAs and ANCAs and just the ANCA driving the disease, no complexes. And, we have the luxury of looking at electron microscopy as well. So the presence of deposits is very, very definitive in these cases, because sometimes you can get fooled at the other end as well, that your immune complexes are there. Now in Pakistan, since you don't have electron microscopy, there are other ways to do it. You can do Moissan's trichrome, and they sometimes help you find where the immune complexes are and so on and so forth. But the same case, if I found a bunch of deposits on the electron microscopy, then my focus would shift back to the ANA and away from the ANCA, because I wouldn't expect deposits with the ANCA. So how would I resolve the issue at that time? I would pick up a paraffin embedded block and send it for pronase digestion. And that may unmask hidden deposits. So there's many different things that go in there, but it's very important to really focus on the pathology that you're looking at, the pathogenic mechanism that you're proposing before you start dishing out treatment. So I think this is a very good case in point from the biopsy standpoint. But once you're dishing out treatment, you can't just stop because the creatinine is high, because you've determined that the creatinine was 1, there's only mild to moderate IFTA at this time. There are a few crescents, but doesn't look like there's overwhelming disease. So this kidney is salvageable, and I wouldn't give up on it.
So we are reaching at like 3 p.m. mark very soon. So I think we had a wonderful, interesting discussion today. Thank you for helping me with my case as well. Let me see if any further questions or comments. I think we probably are reaching at the conclusion of the session now. So you will all receive, I think that email has already been sent out about the evaluation. So please make sure that you complete the evaluation, and we go from there. So everybody have a wonderful, I think, good day and good night. And we all will see you next month.
Thank you for a very comprehensive presentation, Umar. That was excellent. Thank you.
Yes, thank you very much. Thank you.
Thank you so much, Dr. Irfan, Dr. Umar, and Dr. Vas. I think all of you, what are you doing? It's, I think, ye sadke jari hai. Let me say that. And it's a wonderful job that you are doing. Thank you so much.
Whatever we're doing, it's not like one person, but you are also a very important member of the team, and everybody who's participating, and they bring the patients' cases and they discuss, and eventually patients are who are getting benefit out of this. So that's good.
Thank you. Sabko Khuda Hafiz.
Khuda Hafiz.